Welcome everyone to today's webinar, Closing Gaps Now and Beyond Using a Modern Healthcare Knowledge Supply Chain. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. There will also be several polls throughout the presentation. We appreciate your participation. And with that, I'm pleased to welcome today's speaker. John Zimmerman, CEO, Hold On Solutions. As CEO of Hold On Solutions, John sets the overall strategic direction for the company and the Collabornet platform, which improves operational efficiency, care quality, and the provider experience by delivering relevant patient knowledge when and where providers need it. John's career spans more than 35 years, with a majority spent in healthcare, engaging and serving providers and payers with companies such as IBM, Siemens, CareFusion, Allscripts, Ability, and GE. Michael S. Barr, Executive Vice President, Quality Measurement and Research Group, NCQA. Dr. Barr is a board-certified internist and Executive Vice President for the Quality Measurement and Research Group at NCQA. His portfolio at NCQA includes performance measurement development, research, managing NCQA's contracts and grants portfolio, and contributing to strategic initiatives, public policy, and educational programs. Blackford Middleton, Chief Informatics and Innovation Officer at Previta, where he provides a trusted collaboration platform to empower payers, providers, and their stakeholders to transact at scale more efficiently and effectively, clinically, operationally, and financially. Previously, he was a professor of biomedical informatics and/or of medicine at Stanford, Harvard, and Vanderbilt universities. Monica Bolbjerg, CEO, Cure4You, is a doctor, an entrepreneur, and a digital health pioneer. As a young physician, Monica noticed the lack of tools available to engage with and help patients beyond episodic in-person encounters. That experience ignited her passion to create patient engagement and virtual care solutions that improve patient outcomes and experience, while also helping providers drive efficiency. Monica, Michael, John, Blackford, thank you for being here today. And John, I'll now turn the floor over to you.
Hey, Brian, thank you so very much for that great intro. Welcome, everybody. Before we get started, we think it's very appropriate to ground ourselves as to why we are here today. Let's start with sharing our very heartfelt and deepest gratitude to all the healthcare workers who've been working tirelessly for the last year and beyond to keep us safe and to help us get better. We owe you all a tremendous debt of gratitude. We all here on this panel believe in appropriate, comprehensive care for everyone, anywhere. Our job is to make sure that the providers' jobs are as easy and effective as possible. So please know that this is the essence of why we are here today. Further, we all know that we're in an unprecedented time as a result of the pandemic. We know there has been a tremendous amount of chronic care management that has essentially gone without being addressed during this most difficult time. Many call this gaps in care. Also, depending on how care is rendered and documented, we're also faced with an unprecedented amount of gaps in coding, which is also very important. We believe that if we take a step back and look at what are the available technologies today, we believe that we can catch up to where we need to be in a way that sets the foundation to have a better healthcare system overall over time. So when we look at the available technology in our world today, we see a need and an ability to provide a modern healthcare knowledge supply chain because helpful knowledge is created and available. It is just not easy to retrieve. So therefore, it cannot be effective. So how do we see this happening? Well, first, Thanks to the NCQA, we do know what is supposed to be done for any of the key disease states, no matter which they are or where they are. Then, thanks to the analytics companies like Aprovita, we can know precisely what needs to be done for whom and by whom. And with a number of recent innovations, you will see that we can now know how we can get that knowledge and to those care delivery teams when they need it, how they need it, and in a way that they want it. So let's take a look at how all the knowledge supply chain could fit together. Michael will take us through the foundation of how we know what is supposed to be done via creating the quality measures and where that's heading. Then Blackford will walk us through how Aprovita helps us understand exactly what should be done for whom at any given point in time or in the care settings. Then Monica and I will walk through how we take that knowledge and get it in the right hands and minds in a collaborative and effective form between the providers and the patients to help drive optimal outcomes.
John, thank you so much. Greatly appreciate joining you and the rest of the team here. And I know we're still working on the echo, so we'll get through it. I just have 2 slides, and I'm going to spend a little bit of time just setting some background for folks. I know many people are familiar with NCQA and HEDIS, but I thought it would be helpful just to do some level setting. And then we'll jump into sort of the roadmap for the future is on this slide here. So most folks who know, so bear with me if you already know this, but HEDIS includes more than 90 measures. About 190 million or so people enrolled in health plans that report HEDIS. And one of the key aspects that distinguishes HEDIS is the credibility of the measures and confidence that the reported results are as accurate as possible. And this is in large part due to the evidence-based, expert-informed, and transparent measure development process, and the fact that we audit the results, at least at the health plan level, to indicate whether an organization has capabilities for processing medical, member, and provider information to get to that accurate and automated performance measurement. I want to make sure folks are aware that later this year we're introducing another way to validate data and make reporting hopefully less burdensome. The Data Aggregator Validation Program evaluates organizations that collect, aggregate, and transform data such as health information exchanges from the original data sources on behalf of vendors and healthcare organizations. So look for something along those lines later this year. Now, as NCQA collects this information, getting to connecting to the presentation and John's lead-in, we produce several different information sources such as Quality Compass, which is a benchmark and compare, so you can benchmark and compare quality data. The health plan report cards, which focus on accreditation status. Health plan ratings, which score health plans. And the state of healthcare quality, which trends industry performance on select HEDIS and consumer satisfaction measures. I was just referencing, boy, that sounds so much better, doesn't it? Just referencing the Future of HEDIS webinars. So those of you interested, and they're on the NCQA website. But we were focusing on a few things that will come up in my slides here. Allowable adjustments, so the flexibility to adjust within the license the measures for use of the measures and purposes other than health plan reporting, digital measures, reporting methodology, including electronic clinical data systems, and telehealth, which will likely come up also. So it's this future that I want to talk about, that sort of preamble, because we're doing some interesting things and I want to share with you where we're going. So we are examining our measures to determine which of the existing paper-based HEDIS specifications really should be digitalized and made available for download, implementation, and execution from the NCQA's website. Now, that's going to evolve over time also, so it's not going to be the way it is now, but right now we have some digital measures you can download, and we'll be releasing some more in August of this year approximately in FHIR CQL, so converting from a quality data model to FHIR CQL. But there's a remaining set of those 90 measures that we need to consider whether we should prioritize those for digitalization or not. And then as we do so, we're trying to improve them and make them available for multiple levels of accountability and a range of quality use cases. HEDIS for health plans Those measures were designed for health plans, but they're used in multiple different ways and use cases. Part of the allowable adjustments I referred to earlier is to facilitate and designate what kind of adjustments you can make to an NCQA HEDIS health plan measure to use for different purposes. An example might be constraining the denominator value on an age band to a narrower slice than the original measure. That's not going to upset the underlying evidence base or the clinical logic. It might be more useful, or eliminating a line of business from the report out or the denominator, just to focus on if you're using it for population health or so on. So looking at that and thinking about the measures as we digitalize them and as we think about new measures, and that's the point here, is that we're creating new content applicable across levels and use cases by prioritization from the market, looking at where our measures are used for value-based purchasing and other places, outcomes of interest across the health system, gaps in care associated with priority populations, health equity, and so on, inclusion of social determinants of health, social risk factors, and honestly, opportunities to improve or enhance measures through the use of clinical data, recognizing that accessibility to clinical data varies by market, by payer, by delivery system, and so we need to be sensitive to the fact that not everybody's ready to jump in and use measures for reporting on a national level that are based on clinical quality data exclusively. And this next slide is meant to emphasize a few key points as we look at new measures. So measures that address priority populations, looking at prevention and population health, high need and high cost situations. I've already mentioned the second one, encouraging electronic data usage, thinking about longitudinally, can we pull data from different locations to help improve care coordination around a person's needs? And looking at what infrastructure is available to support these kinds of measures, and then trying to push and pull them along the way to get better access to data. One of the key things is looking at measures that align across levels. They don't have to be exact. And by levels, I mean health plan, delivery system, or accountable care organization, practice, or clinician level. Right now, measures are often tweaked and adjusted and create a lot of extra work and burden in terms of matching measures to particular payers, to particular levels of the organization. We think there's a place for measures that could be exact but don't necessarily have to in terms of the clinical content. You might have a utilization measure that is more appropriate for a health plan, but not at a delivery system or clinician level, and a very focused clinical measure that's at the clinician delivery system that's helping to drive care at the point of care. If you look at those measures as a portfolio or a group, they actually all point in the same direction, leveraging similar clinical logic, but different applications. And maybe we can get into that because I'm not sure I described that as adequately as I'd like. Again, I'm trying to make up some time here. And then multiple use cases. So high interest in use of measures for accountability and reporting and value-based purchasing. But we often also need to focus on population health, improvement at the point of care, delivering clinical decision support to drive improvements at the individual level. So I went through that rapidly. I know we have other speakers, and I apologize for on behalf of the team for the technical difficulty. But let me turn it now back over to John. John?
Hey, Michael, thank you so very much for really setting us a great vision for our journey going forward. We're at the beginning of a next wave. So if you think about what Michael just kind of put out for us to be considering, maybe we could get a little information from you all about what's your experience been in accessing, the ease of accessing information outside of your own organization, things that you might have to go to a portal for. Are you finding that A, you're getting too much or wrong information, B, just about right, or C, not enough? I'll wait a little bit for you guys to make your selections. Nice pregnant pause. I can't wait to figure out what that echo was, what created that echo. And hopefully that is now in our past, not in our future. Okay, I see a couple more coming in. Don't be shy. Ah, wonderful, more coming in. That's great. Keep them coming. Excellent. If I can get just a couple more, we'll call it a day. Thank you very much for everybody who's making them happen. Okay, we're plateauing. Let's go and see what it looks like. Each of these, the top and the bottom, are really important. Not enough information gets in the way, and too much and wrong information also gets in the way. So we see, unfortunately, only about 78% maybe 78% are getting not enough or wrong information or too much. Not good. We have to do something about that. So with that said, let me transition over to Blackburn Middleton so he can talk about how Aprovita helps us make sure that just the right information is available for use in workflow. So may I turn it over to you, Blackburn?
Thank you, John. Can you hear me okay?
Yes, sir.
So thanks for the invitation, John, to participate with this esteemed group. It's really a pleasure. And as you say, delivering insights into the clinical workflow when and where clinical decision-making is occurring is the key to transforming U.S. healthcare as I see it. Let's see, can I go to the next slide? There, whoops, too far. The system of care that we live with has been severely stressed by COVID-19, as you say. We've seen gaps exposed in data management, in clinical care and public health, and in the face of rapidly evolving clinical understanding of diagnosis and treatment for COVID, doctors and care teams often were not informed with the latest and greatest best evidence. I can talk more about how Aprovita engaged in the fight with COVID, against COVID in Q&A if people are interested. But bottom line, doctors need to be delighted, not burdened with insights or measures that are useful and with CDS that is actionable. We don't need a hammer over the head, we need cognitive support. We've made significant investments in EHR infrastructure in this country with high tech, but we're not achieving the potential value return on this investment that I and several others predicted. We modeled interoperability as being worth approximately $78 billion a year in ambulatory care alone. At the Center for IT Leadership at Partners Healthcare, we modeled advanced clinical intelligence and cognitive support in ambulatory care alone being worth $44 billion a year. Advanced acute care, CDS, from John Berkmeyer's studies, thought to be worth $30 billion a year. So in the aggregate, what we're talking about here, both in response to COVID-19 and going forward, is truly transforming care finally with health IT to support this entire knowledge ecosystem as John has outlined it to you. We could save potentially $150 billion conservatively, or approaching 5 to 10% of U.S. healthcare spend. We're not achieving that for several factors. First, true interoperability, as we've mentioned a couple times, of healthcare data or data liquidity so that it can flow from where it is to where it is needed for clinical care, research, and public health. We're making progress in these areas with the final rules on information blocking from ONC and CMS as we move as an industry toward FHIR, as Michael's already mentioned with measures. Second challenge has been around usability. The EHR docs are using haven't always been up to par or up to snuff in usability, but we're refining usability with ongoing experience in our clinical systems to think more like doctors and not like billing clerks. In addition to workflow, I've always said that we need to support a clinician and the care team's mind flow in the decision-making process, whether it be diagnostic considerations, therapy, or care coordination across the full continuum of care, not just in one EHR alone or in one care setting. So we're making significant progress on interoperability and usability, which leads me to believe, because of our progress in knowledge exchange, that we're truly approaching an inflection point in U.S. healthcare. This idea of creating a system of insight, as you see on this slide, we deploy a system of insight that sits on top of the EHR and patient engagement or management tools, and provides value-based care management tools, quality measurement, and clinical intelligence. We aim to write a knowledge artifact in this platform once and reuse it many times over. This can dramatically reduce the knowledge engineering burden in this country, which we've estimated to be about $25 billion in ambulatory care alone. In this manner, we can help close the 17-year gap between the discovery of new clinically useful knowledge and its broad adoption in practice. We need to rapidly update computable knowledge and make it readily available in the system of insight so that we can optimize care and keep it up to date and create the learning healthcare system. APRAVITA, let me get there. APRAVITA truly enables this learning healthcare system with our partners. Our mission is to empower payers, providers, and their stakeholders to more efficiently and effectively transact at scale, clinically, operationally, and financially. The VITAL platform brings together the elements to create this learning health system and support the near frictionless flow of interoperable data and computable knowledge. Why is it that we have to deploy sophisticated quality measures repeatedly across disparate EHRs? This can lead to unwarranted variation in measure results, preventing true apples-to-apples comparisons of care delivery. Or why is it that we have to, if I create a superior evidence-based peer-reviewed clinical pathway at the Brigham and Women's Hospital, I can't simply send it to my colleagues at Intermountain and have them use it in their systems. We should live in a healthcare IT world where my clinical systems, whether it is quality measurement, value optimization, or clinical intelligence, can be updated as quickly with new knowledge as it becomes available. So we're working with others across the industry to create a seamless healthcare knowledge ecosystem to ensure that composite knowledge artifacts made up of various technologies, value sets, logic expressions, and the like can work together with assurance and appropriately. We think of this as the knowledge supply chain, as John alluded to, or the national knowledge ecosystem. Imagine if an automobile supply chain didn't abide by universally adopted standards for its parts or the parts of a car. The wing nut made in Ohio or the transaxle made in South Carolina might not fit the Chevy being built in Detroit. Similarly, we need to ensure that the U.S. national knowledge ecosystem works in a coordinated fashion so that knowledge producers, whether it be a quality measurement spec, a value-based contract, or a computable practice guideline on fire, can be written once and can work in each and every care setting. So this is the way, we believe at APRAVITA, this is the only way we can ever hope to truly enable precision medicine and the patient-centric learning system. As we envision the future of precision quality measurement and precision diagnostics and precision therapeutics, it's simply going to become impossible, if it isn't already, for the average clinician at the point of care to keep track of it all. And we aim to provide these cognitive tools, quality measurement, and value optimization to those clinicians and care providers and payers as need be. Thank you for your time and attention, and let me reiterate what a pleasure it is to be on this panel with like-minded folks.
Blackford, thank you so much for those insights and some really stimulating, innovative thoughts and in a great ecosystem view. Let's turn back to the audience and think about or get their opinions today. So audience, here's some more opportunities to get your thoughts. We're really interested in how you see your gaps in care for your patients or members right now. Are you seeing more gaps than usual? Are you seeing about the same, or are you seeing less than you've seen before? So just kind of getting a sense of how much you're seeing out there in our near post-pandemic world. I'm going to wait for a few minutes. Thank you for all who are making their selections. This is very instructive to us on this panel. And I hope you all are getting a great sense of, you know, the flow of what we need to do and then the flow of making sure that we have the right insights to be able to do the right things We're about to get into the view of, well, how do you get that knowledge into the point of care with what I love Blackford's term of cognitive support. Very important term, I think, as we all go forward. We're getting more than last time. This is good. Okay, looks like we've leveled off some. Let's take a look at what the poll says. Okay? Yeah, not surprising. More gaps than usual, which means that we have a heck of a backlog to go get after. So thank you for your input. I'm going to take the podium from here and start to talk about what we can actually go do about this. So as I just said, as you've seen from Michael's and Blackford's presentation, there's a new availability of knowledge that can be delivered directly into the workflows of the providers and also, as you'll see, to the patients themselves. So we are trying to make sure that that knowledge enables the right action by sensing users, creating context, and delivering that content right where they need it. What the providers get is curated knowledge in context to address that cognitive support, okay? And it's typically used by both risk-bearing entities and providers. So I'm going to walk through now how this works, okay? What we do at Holon is we deliver that precise, pertinent, and personalized knowledge from any source based on how and where it is needed. What we've been able to discover is a way to, and we've created patented workflow sensing technology so the users don't have to know where to go. What the users do is they just continue to operate in their EHR as they normally would. We operate unobtrusively behind the scenes, so we do this so users don't have to. We establish that shared context of user, what they're trying to accomplish, in other words, their task, and the patient they're serving at that moment, okay? We then retrieve that authorized knowledge source for that encounter, retrieve that information, and present it to them in a complementary assistive user experience that they can put on screen or move it around wherever they want, and even in a very small ribbon, okay? This enables the providers to focus and know exactly what they need to do to take the best actions for the patient. That's the expression of cognitive support. They don't have to hunt for knowledge that they need, as it is precise and personalized and pertinent, and it's delivered to each provider to maximize their convenience for doing the right things for maximum adoption and impact. So if we now can look back and try to think about, we know what to do from Michael's work and the NCQA's work about the appropriateness of actions at any point, and then Blackford's ability to take the data and curate it and ensure that that knowledge is expressed in a way that can be acted upon. This is the point where it actually gets acted upon in the encounter, at the point of care. That's why we deliver precision information delivery directly into their workflow. I'm going to turn now to ask you what you all are now experiencing. This is the third and last polling set of questions. Which gaps are most prevalent for your populations? Is it preventative screenings? Is it follow-up service from a previous encounter? Is it unfilled prescriptions? Are they mostly now behavioral health? Or is it community services or any other thing that you're seeing that is necessary to be addressed in the populations that you all serve? We had a great set of responses last time. I'm going to give it a couple more minutes. As I'm waiting, I just want to make sure that we're teeing up Monica and her team properly. It's super important for the providers to know what to do. It's equally, if not more important, for the patients to know what to do as well and how to seamlessly engage with the providers themselves. the better that we can coordinate the activities of providers and the patients, the more likely we are to not only close the gaps that we have today, but establish a new platform for us to be able to have a better healthcare system than ever before. Okay, our response rate is leveling off, so let's take a look at what the survey tells us. Lots of preventative screenings, follow-ups, I think lots of referrals in that. Yeah, unfilled prescriptions is a big deal. Behavioral health and community services, referring back to one of Michael's early points on looking forward into SDOH. Audience team, thank you very much for your insights. We're going to use this information as we go forward. Monica, I'm now going to turn it over to you to see what the knowledge supply chain can look like from the critical perspective of the patient. Monica?
Thank you. Thank you for having me here. Yeah, so my background is I'm a physician, and the reason why I'm doing what I'm doing today is because I saw the value of giving patients better tools and better include the patients in their care. And the why is that if you engage the consumers more in their own care, you'll get improved outcomes. And with that, you'll get richer data, you'll get better care, and you'll get improved outcomes. But in order to get there, you need to think about how can you interact with patients without it being only when you see them in the office. So what we're doing and working on, and I've been doing for more than 20 years now, is like, how do we use technology to interact with patients and engage them when they're not together with the providers, or everything that's outside of what's happening when providers and patients are together. And so the way we look at it is really looking at a circle of care for the patients and the different components, what we can do there to kind of engage with the patients when they're at home, when they're trying to get into their doctors, and what's happening in the visit, during the visits. And so we're looking at having multiple touch points with the patients to really engage them throughout their journey of care. And the engagement piece is to create awareness about their health. We really want them to know why. Why are we asking patients to do that, right? We have the preventive screening not getting done. A lot of times the patients don't even understand the reason why. What's the risk for them not getting the mammogram or the colonoscopy? But another thing we also want to do is we want to close what we call easy gaps in care. Like, for instance, did you get your flu shot? And if yes, give me that information, and the platform will put that information right back into the right place in the population health system, and then sure. And then use telehealth and secure messaging to communicate with patients throughout their journey of care to make sure they stay engaged. If we want them to come in, we want to make sure that there's no barriers to care. We really want to improve the access to care. So think about patient is due for a colonoscopy. Instead of calling them or waiting until they show up in the office, let's make sure they have a button they can click, and it will take them directly to online scheduling in the facility where we want them to go. And while they're on their way in there, we want to make sure that anything of pre-arrival screening, any kind of things of consciousness check-in, the drive-off for safe arrival, all that is done using technology and not people, because we really want to remove the barriers to care and improve the access. When patients and doctors are together, some of that data, or a lot of that data that Blackford and John and Michael has been talking about, absolutely should be in front of the physician. But we also want to make sure that the physician can review digitally collected at-home patient data. And we want to make sure we get that together, bundled together, so all the data is together. And then now we can use that to put clinical decision support tools on top of it. Because we want to make it really easy for the provider to individualize treatment and not say, oh, this is hypertension, and this is diabetes type 1, and this is just it. We want to give more data to the physician so that he can get better understanding of the patient that we are looking at right now. And when we send patients home, we want them to go home with a digital care plan. We don't want the patients to leave empty-handed or with an instruction in paper that is printed out. We want them to go home with a tool so they can work together with the care team and improving their care. Because then it comes to the next piece. Once we have them engaged, once we send them home with a tool, now they're interacting with that care team. Now we can collect even more data. We can give them remote monitoring tools, so Bluetooth connected devices that monitors their health at home, give us more data, right? We can give them at-home tasks. Tell them now it's time for you to take your medication, or you need to remember to fill out this screening questionnaire right now. And at the same time, we can monitor all that real time, and we can send alerts to the care team if the patient is non-adherent, or if the patient is reporting vitals or any kind of signs that say, hey, there's an alert right now. This patient is going in the wrong direction. And this is now where we can go back to looking at in the engagement again, and it all goes back full circle. Sorry. Yeah. So using a virtual care platform strategically can be very effective and impactful, but I want to touch on a couple of things here. What it will give you is it will give you fast access to more data. It will give you richer and more accurate data, but it will also give you a collaboration platform that you can really work with your patient on an ongoing basis. But to get there, there are a couple of things that I want to kind of share from my experience having done this for so many years, that are kind of must-haves to think about. Field-to-field integration with your EHR, and typically multiple EHRs, is really, really important, right? You don't want it to be a unidirectional, just send something to the patient or just send something back to the doctor. It needs to be bidirectional, and it needs to be a platform that covers multiple EHRs so that you can have an umbrella platform, one patient engagement platform that is used on top of all your systems. And with the technologies that are out there today, it's also really easy to show this data and put the experience for the provider as if it is inside the EHR. So things can be framed in, or you can use Chrome extension tool. There's a lot of tools out there today that makes the experience really smooth for the provider and staff, so they feel like they're inside the same system as they work with today, which would remove those barriers to adoptions from the staff and the providers. And then make sure that all the platform is supported on all devices, right? So it shouldn't be that your patients can only use an iPhone. It should just support Android as well, tablets, computers, and same for your providers and staff. Make this a seamless experience, because when you do that, you can get to very high patient adoption. So make sure you get some numbers from whatever virtual care platform you want to choose out there. Ask for adoption, because done the right way, you can get to more than a 90% patient adoption using the right tool. So with that being said, I will turn it back over to you, John.
Monica, thank you very much to really cap off these insights, to be able to deliver not only to the point of care, but to the person who's receiving the care and ensuring that they're engaged. Thank you very much. Team, I'd like to now open it up for just basic Q&A. So we're going to open through our moderators to look at some of the questions that you've been sending in. Thank you for those, and then I'll direct people who are going to engage on providing some good answers for your questions today. So Brian, I think it's back to you.
Absolutely. Thank you so much, John. And thank you, Monica, Michael, and Blackford as well for a great presentation and sharing your expertise with our audience today. We will now begin today's question and answer session. As a reminder, you can submit any questions you have by typing them into the Q&A chat box on your webinar console. So we'll get started with this one. And John, throw it to you. And as you mentioned, you'll delegate these out. So the first question we'll ask is, how has the huge uptake of telehealth affected the flow of information?
Wow, I think that it'd be great to start that with Monica, since she is right square in the middle of it. So Monica, do you think you'd like to answer that, please?
Yeah. So telehealth really went from less than 1% to 60% overnight, which was a huge revolution, and it has kind of stayed at around 25 to 30% going forward, which has changed a lot of the way we interact with patients today. What is happening now is that a lot of the data that typically was collected using an in-person visit today is collected using screening questionnaires that are kind of sent to the patient prior to a telehealth call. And so we make sure that those gaps are closed prior to the visit as well. I think we'll see this change a lot over time. I mean, telehealth is really going to be like a more like kind of fluid tool that is used in the care in multiple different situations. So I think it initially was kind of like replace a visit. Very soon, I think we'll see a lot of creativity around how do we use this for like a quick check-in or really just engaging patients at the right time, or we need this data right now. Let's just make sure we get it and follow up with a question using a telehealth visit.
Thank you, Monica. Blackford, Michael, anything you'd like to add there?
Yeah, John, it's Michael. Let me just weigh in really quickly. Totally agree with Monica, and I'd just like to point out that in recognition of the growing use of telehealth, in June of last year, NCQA added telehealth codes to about 40 of the HEDIS measures. So we should start seeing from the data being reported this year, the following report, how telehealth was used to support HEDIS, meeting HEDIS requirements. So I thought that would be interesting and hopefully valuable when we look at it.
Great, and I think, you know, part of the big point here is that knowledge supply chain is still going to be, is going to be even more necessary than you saw today as, excuse me, more and more care is going to the home. That is an inescapable direction. I encourage us all to follow some of the great work being done by the American Academy of Home Care Medicine as we see these confluences of activities going forward. So thank you both for those responses. Brian, more questions?
Yeah, definitely. We've had some great engagement, really, really wonderful to see. So the next question I'll throw out there, John, is the attendee asks, how do you advise we work with / engage patients with little to no digital tools to schedule preventative care?
Well, I think that's another fabulous question for Monica. And if you look at the bottom of her slide, it says high patient adoption. I bet you've had a little bit of experience there, Monica.
Absolutely. So I would say like 25% of all users of our platform are FQHCs. So we're very, very familiar with the challenges of patients with little or no digital tools. I will say, I mean, there will be some that you just can't reach, right? But most patients we have learned, even though they are not really skilled themselves or have the tools themselves, still prefer to interact digitally, but then they'll get a family member or a friend or somebody like that to kind of like interact for them or on behalf of them or together with them. You do need to have a patient support, a technical support capability if that's your population. At Cure4You, we offer that as part of our service to kind of help with that. So we have like skilled people that know how to help people that are not very technically savvy. And for some of those, we recommend getting them on a mobile app because there's no login, and it takes a little longer to get them there. But once they have it, they are actually really engaged going forward. And all of them are so grateful for the help to get them onboarded onto using these tools. And going forward, they all use it.
Great insights, Monica. Thank you. Brian, more questions?
Yep. This one is directed directly for Blackford. So the attendee asks, many systems claim to be knowledge managers. How do you differentiate one from another?
Hi, David. Thank you for the question. You know, the bottom line is the notion of a knowledge manager has to do with maintaining the corpus of knowledge assets. That is, all of the elements that might make up a composite knowledge object, whether it's a numerator and a denominator of a quality measure, or whether it's an e-pathway with state definitions, recommendations, and actions and actors, or even it's a value-based contract with parameters and medical loss ratios and the like. So the knowledge management system can keep that all in sync, but a knowledge delivery platform not only manages the knowledge, but allows you to build, test, provision, and execute on those knowledge assets. So that's the key difference. At Partners Healthcare, for example, we build a 50-person knowledge management team to manage all the assets in our distributed systems and whatnot. At Partners Healthcare, we were very fortunate and able to do that, had the resources to do that. But the average bread and butter clinician, hospital, and healthcare delivery system across this country cannot simply possibly keep up with the rapidly evolving knowledge base. So that's where I think you have to turn to a professional knowledge management system and then couple that to the build, test, provision, and execute platform, or the knowledge delivery platform as I've described today. Does that make sense, David?
Appreciate you tackling that one, Blackford. And the next question I'll throw out to John to sort of delegate here is the attendee asks, what is the best way patient self-reported information might be collected and added into the mix of information?
I think that's another great one. So Monica, do you want to start there? Because you're going to be doing the sort of the collection and perhaps some of the aggregation side. Then Blackbird, maybe you could follow on with how your aggregation and curation platform for knowledge helps there as well. So Monica, Blackbird.
Yeah. So for collection of data from patients, there are multiple different ways of doing it. Typically, what we use is we kind of talk about protocols, and we use an underlying system to kind of like be the engine about what is it we need to capture from that specific patient. And so you can digest that down to like kind of age, gender, current gaps in care, what is their diagnosis, and what are they scheduled for next time. And all that data then can be captured from patient depending on what it is. There's a lot of different ways. It can be a simple question you ask, and then that data is collected. Or if it's a lot of data you need, like from vitals, you will use an integrated device to kind of get that data. Sometimes it's a screening question. It really depends on what type of data it is in that specific situation. And then it's not hard to get it from this. More like setting up the rules and connected it to the engines behind that, kind of saying like the whole system saying like, well, this specific patient, we need this from them now.
And Monica, I would just agree with everything you've said and underscore a couple of other thoughts. Add a couple of other thoughts. One is, this notion of patient-reported outcome measures or patient-derived data, patient-source data capture occurs not only when the patient is remote to the clinical encounter. It may, in fact, also occur when the patient's in the office. If I need to differentiate the risk of this patient having gonorrhea, I want to use a Vancouver risk interview scoring tool in the course of my interview of that patient. So, that fact of both in-clinic and out-of-clinic data gathering, as well as sort of the notion of the synchronous and asynchronous. What can I gather automatically and in perpetuity versus what do I ask for on demand? But the final thought, just as a clinician, I'd say the most important thing we need to do for our docs is to distill the data into a useful signal. That is, so I'm not overwhelmed with a daily, home glucose measurement or assessment, but I get a sense of trend or, distillation of the data into an insight for me when I'm seeing that patient in 12 minutes for diabetes follow-up.
Absolutely, I
John,
totally agree.
I'm sorry, Monica, go ahead.
Go ahead, Michael. Yeah, please.
Well, I just want to add, appreciate Monica and Blackbird's comments, and I just want to add a little bit with respect to person-driven outcomes, which is an area of research that our team has been working on. It's essentially, right now, in people with multiple comorbidities or complex patients who, for which a particular guideline may not really address what matters most to the person. And so this is really about sort of coaching and helping people identify what matters most to them and setting goals and expectations associated with it. Not necessarily with a structured patient report outcome measure or PROM, but with actually a narrative expectation and selecting goals. It's been very rewarding for the people who have asked the questions and for the clinical team members that are participating in that project and the work. And in terms of outcomes, the research is being finalized, but it's shown some positive aspects or positive effects on the actual quality of care and utilization. So I say that because one of the big challenges is getting the information into the workflow of the clinical team so they can document and track and trend. And so it would seem to me that in addition to the solutions we're talking about now, we should focus on, as Black was saying, in the office or asynchronous with the office. So what Monica was saying, how do we collect those perspectives from people, manage to them, and help them achieve what they feel is most important to their health and their wellness?
Well, you guys really just encapsulated not only the value, but also the importance of the healthcare learning ecosystem, because we know that we're on a journey and technology can help enable us. So thank you for that great question and those super insightful answers. Brian, I think we have time for one more, maybe two. Let's see.
Yeah. Definitely at least one more question. So that one will be, can Holon ingest/display payer data? So John, I'll throw that to you, and I know you got some closing comments as well. So let's see if we can get through this question.
Okay, I'm going to make this simple. The short answer is yes, that's what we were designed to do. As we also know, the term payer is now beginning to incorporate different flavors of risk-bearing entities, whether they're part of a healthcare enterprise or whether they're a traditional payer. It is super important for the providers to have an assistive as well as common user experience from any source of knowledge, and that was one of our key design points. It is our job to try to make the delivery of precise pertinent information into their workflows, precise pertinent knowledge into their workflows much easier. So, and payers have a lot of high value information that should be placed right into those workflows. It'll make such a difference in contracting, care delivery, and a number of other areas. So with that said, I'm going to try to land this great webinar from these terrific colleagues. I hope you will agree with me that we are so blessed to have such a great panel working with us today. I want to summarize by saying that we greatly appreciate your attendance and engagement in this webinar. I'm going to close out with the following summary. Look, we all believe in appropriate comprehensive care for everyone, anywhere. We also know, and you've confirmed, that the pandemic has left our healthcare system with more gaps and disparities than ever before. We also know that we have the knowledge on what we all should do for whom, when they need it, wherever they are. We have hopefully demonstrated that by working together, leaders in our industry can apply our collective knowledge and experiences to help our nation recover now, while delivering a smarter and more effective healthcare system than we've ever had before. So our call to action is very simple. Please engage and stay engaged. Assess your needs. Ensure you're focused on your success criteria wherever you may be in the healthcare ecosystem. Assemble your team, be it internal or your external partners. We know that companies like NextGen, Cerner, Quest Diagnostics, Veradigm, and others are really doing great work for laying the foundation for the new knowledge supply chain. Let's be cognizant of augmenting your systems and your stakeholder systems. This is not a time or a reason for ripping and replacing. This is a time for collaborating and extending. And we implore all of us to always stay focused on the improving the outcomes being our end result. Improved outcomes for the patients, the providers, and all stakeholders in our healthcare ecosystem. So let's go close our gaps, and let's do so in a way that sustainably improves the performance of our healthcare system for everyone. Thank you again for your collaboration, attention, and engagement today. We look forward to following through with any and all of your requests. We'll see you out there. Look forward to engaging. Thank you for your attendance today. You all take care. Be safe.